on the 11th hour of the 11th day of the 11th month, which in England was about 20 minutes ago, we have 2 minutes silence to commemorate all of the dead from all wars. But with 8 minutes to talk, 2 minutes might be too long to ask you to be silent. It's a real honor and a pleasure to be here to talk to you, to celebrate your 80th anniversary. My conflict of interest is also the reason that I'm here. The Real Health Institute celebrated its 10th anniversary in Holland last month. And it's been great to be a partner with you over that 10 years. I don't want to be negative, but I've been in spinal surgery for 25 years. And we've been through a cycle of using surgery to treat back pain, which is coming to an end, which is why I chose to give this talk today. I want to pose a series of questions about the role of surgery in treating low back pain. And it doesn't mean that spinal surgery is bad. Please don't get the wrong message. Spinal surgery is utterly wonderful, life-changing, and brilliant. But the problem comes when we apply modern surgical techniques to non-specific low back pain, precisely defined, and excluding structural problems in the spine. And I'm not talking about surgery for leg pain or sciatica. I'm talking about surgery for back pain. And I've put up some pictures of the type of things that I suppose came from hip and knee replacement engineers that we've been using over 25 years of my clinical practice to treat back pain. The first question, a pragmatic one, is it happening? And the answer is yes, it is. These figures from the States, but these show an exponential growth in the amount of surgery for low back pain and an exponential growth in the costs. Is it accepted clinical practice? All these questions are very carefully phrased. And the answer is yes, it is. The National Institute in England, NICE, that synthesizes evidence for central government, spent €1 million on the 2009 guidelines. And it's more than accepted practice. These are the only guidelines in the world that recommend this surgery for low back pain. So it is accepted practice. I had hoped I could bring you the 2016 guidelines, but their release has been delayed until the end of the month. And so I can't bring you that information because I'm not allowed to. Is it evidence-based? This is where we start to have a problem. The top left graph compares surgery with non-surgery. On the left is non-surgical treatment as usual. The surgery is better. The three right-hand bars on that chart compare surgery with structured non-surgical care, the type of thing that we've been doing with you here for 10 years. There's no discernible difference. And if you look at the bottom left-hand graph, again, this data will probably never appear in press, but this is the likely impact of the surgical treatment for back pain after 7 years. So if it works, it doesn't seem to work for longer than that period. The top right graph is a non-inferiority study comparing disc replacement with fusion. And it's not inferior. That's not a great marketing line, is it? But nonetheless, it's not inferior. But as orthopedic surgeons, we should remember where we've come from. Survivorship in hip replacement and knee replacement is the evidence with which we've sold these treatments to the world. If you look at survivorship in total disc replacement on that bottom right-hand graph, if I came to you with a new hip replacement with a 60% survival rate at 10 years, you would throw me off the stage, or I hope you would throw me off the stage. And yet that's what it would seem we're offering patients with the same thing in the spine. Miranda, who's in the audience here, has helped various people develop a new way of looking at outcomes. And this is using a well-recognized outcome score and saying that if you get beneath the horizontal line on this graph, your level of disability is equivalent to normal day-to-day function. It's a very different way of looking at it. And if you look at the surgical data, one of the graphs I've just shown you, only 20% of patients in a surgical study get beneath that line. In some of the data that we've generated locally, up to 50% of patients are moving from a similar starting point into a clinically very useful and meaningful outcome range. Is it cost effective? And this is another study comparing surgery with structured non-surgical care. And you can look at the numbers, but in reality, the surgery costs about twice as much. And as I've already hopefully shown you, there's no real clinical yield compared to the non-surgical alternative. Was the guidelines recommended? I mean, we're about to leave the European Union, I think, and we're a bit uncertain, if I'm honest, but we probably will leave. And you guys might leave, from what I hear. And you may not respect our government. Most of us don't. But in reality, 2013, the National Health Service, the biggest healthcare delivery organization in the world, said it would no longer commission surgery for this diagnosis. Ladies and gentlemen, that's a very big statement. So as I head towards closure, on a very brief description of my personal journey over this last 25 years, I think when I set myself the task of talking about is there a role for surgery, I had to see it from different viewpoints. From the perspective of a fully informed patient that understands what I've just described to you, then I believe the answer is yes. But if I was a purchaser of that healthcare, or I was in central government, on the basis of the evidence that we've generated, I would have to say no. It's no longer a valid treatment in treating non-specific low back pain. Again, it's been an honor and a pleasure to be here. And as I close, I would like to wish you a happy 80th anniversary. Thank you very much.